The first case is from Rama Thibadi from Dr. Nachapan Peng Rung. Please.
Good afternoon, Chairman, Co-Chairman, our faculties, and our panelists and our participants. My name is Nachapan Peng Rung from Rama Thibadi Hospital. Okay, let's start with the case. 81 years old woman, she had left hip pain for 1 hour. The pain occurred after the simple ground fall injury, and she also had hypertension, dyslipidemia, and osteoporosis. And she was referred to our hospital due to the treat out of current medicine in our hospital. This is the initial radiograph. You can see that it has simple medial weight fractures at the mid shaft of femur. And if you look carefully at the fracture, you can see that there is some lateral cortex thickening. So at that time when patient was sent to my hospital, I reviewed her current medication and found that she take alendronate for 5 years. And also no any prodromal symptom or both type pain. And this is the latest BMD about 2 years ago. The BMD of spine and the hip quite good, I think. So I think at that time she was treated with alendronate by gynecologist. I think it's due to abnormal of the FRAX score. And we checked to the contralateral side and also found that there have a cortex thickening and no any pain and no any broken rising. So at that time, I diagnosed she was a typical femoral shaft fracture of her left femur. So I decided to perform the operation with cord reduction with internal fixation by reconstruction nail on the left femur. In my institute, we prepared to perform in lateral decubitus on the radiocent table. So it is intraoperative fluoroscope. Because of her loss of soft tissue and the short fragment of the fracture, we cannot achieve the reduction by coarse technique. So we turn to mini open and put the bone reduction cam to assist the reduction and check the reduction and rotation by visualization. This is the post-operative radiograph. In intraoperative, the nail was very fit to the proximal fragment. So when I try to use the reconstruction mode of the nail, the fracture is rotate and malrotation. So we change the plan to interlocking mode. And if you look at the cortex, you can see that the lateral beak like this, and the alignment, the rotation at that time, I think it's okay. And for the post-operative management, as you know, we stop the alendronate administration and add calcium vitamin D supplement and give her teriparatide injection. And because of the acceptable reduction, I allow her to perform the partial weight bearing with gauge 8. And look at the follow-up X-ray 6 weeks. You can see that there are some cracks at the anterior cortex of the lateral proximal fragment. And 3 months, the same, and no any callus progression at the fracture site, but I think in the crack fragment, they have some callus on that. And for 4.5 months, the fracture of the crack is look here, but the first fracture is still the same. And you can see that the position, when compared to the last one, I think is a little bit last change. And if you look at the screw, the distal screw have broken already. So I would like to ask my panelists, if the case is proceed to this, do you have any comment or recommend the management?
Before my answer, I wanted to ask one question to you. What is the average union time for this kind of atypical fracture?
Oh, you mean
Average union time.
I think it's about 6 months at least.
Yeah, right. Data shows 6 months.
Yes.
So the fracture healing mechanism is disturbed. We
Yes.
expect a longer period of union time.
Yeah.
So initial surgery, the reduction is very nice. However, I think the stability is not good enough. The typical, the general, the fracture, this is okay. However, this is we have to wait a long time, at least 6 months. So this kind of atypical femur fracture, we should acquire more stronger stability. If I were the doctor, I took 2 interlocking screws, 2 blocking screws to distal part, and proximal part I should do the supplementary screws. And then 3 months or 4 or 5 months later, the X-ray shows the displaced translation to lateral
Yes.
cortex, and the screws are broken and pulled out, and you can support already the nail is sinking down.
Yes.
So that means the instability.
Yes.
So we can expect, we can wait for a long time, but I think the possibility of healing is very low. So we cannot determine diagnosis of non-union at this moment. I found the problem, so I will try to fix the problem. So the problem is the mechanical stability. I will do the plate augmentation, and then do some kind of the biologic enhancing material, autobone, or for me, the BMP2 preferred. So we have the 2 kinds of this, stability and biologic, both of them. Is my opinion.
And do you gonna change the nail or still
No
use the
exchange
same one?
nail, just augmentative plating. Yeah, if I want, so I'll do the cephalomedullary screws, or if not, because of the version of the nail, so I'll do just with not through the nail hole, just augmentative prophylactic fixation of the cannulated screws from the femur neck.
I have a question about the size of the nail at the initial nail that you use.
9.
9.
Yeah, we overlean to 10.5 and use 9 nail. Yes.
And about how panelists, how large of the nail size that you prefer, bigger than 9, bigger than 10, or not?
I think that it depends on how we can achieve the reamers, because we need to get a bigger reamers around 1.5 to 2 millimeters. So I will choose the biggest one as we can. But the problem is the endosteal, with some time is block the reamers, and also the diffuse thickening of the femur. So that's make reamer a little bit difficult.
For typical femoral fractures, we need a thicker nail. But in a typical femoral fractures, there can be a risk of iatrogenic fractures. So we need to overring at least 2 millimeter or overreaming by 2.5 millimeter. And I think, and again, when we reaming, we should avoid, and also we should avoid thermal damages. So we should choose nail diameter just to fit the patient's femoral medullary canal.
And would you show the X-ray of the fracture site? The reaming, the larger diameter of the nail provide along the stability. Usually, atypical femur fracture is subtrochanteric area or the mid-shaft isthmus. However, this kind of fracture, there's the butterfly fragment and isthmic area. So even we have enough larger diameter of nail can provide enough stability. In this kind of fracture, we should more stability for distal fragment. We can do many interlocking screws, or the blocking screws are very easy to acquire the stability.
Thank you for your comment, and I agree with you that the nail is okay and it's just lose only these tall parts, So at that time, I decided to revision at that time with distal femoral. I use the same nail, not change, just remove the screw that obscure the plate position and use the distal femoral LCP augmentation and also the iliac bone graft. And then 2 months later, after revision, I also allow her to put the partial weight bearing. And I see that there are some crack at the proximal most screw, and she still no pain, and she still want to walk, so I allow the same protocol. And then the 6 months after operation, all proximal and the distal, all proximal screw of the plate and all distal screw of the nail is broken, and the fracture is still not healed. Yes. Do you have any comment?
I want to say one thing. What was the post-operative course? What was the management of weight bearing? Did you let the patient weight bear?
Partial.
Partial, okay.
Yes, partial.
And I really think that precise reduction is very important. And if it's not achievable, maybe you could add a supplemental plate at the beginning. So that might be also key. And like Professor Kim said, that the stability is very important too. So very precise reduction and also maybe supplement plating is key, I think. Thank you.
And now for this factor, I think all of you agree that
My solution in this at this moment, we have to provide more stability.
Yeah.
So in the first revision, I used a longer plate because the proximal part of the plate end should be placed just below the great trochanter. We can fix more screws through the lesser trochanter. It's very enough, and maybe about 38 or 40 millimeter cortical screws. And in Korea, I can use the attachment plate. So we have wing. So this attachment plate gives more stability to many screws. So the problem is the stability.
Yes.
So we have to give more stability.
So at that time, I remove all plate and nail and use the bigger one, number 11, and change the fixation to the medial side. So I use the medial plate augmentation. And I also use the iliac bone graft and BMP2 augmentation as well. Okay, this is the post-operative radiograph. I still allow her to do the partial weight bearing. And this is 6 weeks and 3 months. At 3 months, I think they have some hard collagen. So now I allow her to put the full weight bearing, and she still no pain after that. And this is the latest X-ray, about 5 months after revision. I think the colors is more, even in the anterior and posterior cortex, and no any change or any loose. This is the latest one. Do you have any comment?
Yeah, good job.
Thank you.
And this the atrial film fracture is basically the suppressed of bone healing. However, we always consider the stability. Yeah, the main problem is the stability problem.
Yes.
So we have to solve this mechanical with rigid fixation. And nailing and augmentative plating is good. However, in nail distal the screw placement, so we have to. In last revision surgery, you got proximal part at least four quadricular screws at a cortex, right? So enough stability. So it's a good option. And then the one of the master, the CW is ready to answer.
May I ask you, the panels, when you see that the case, fresh case like this one, the infra-ischemic AFF, what's your treatment? Hero and G1 and Loratep? What's your first choice, not the revision choice?
Okay.
Yeah.
My first option is still nail.
Only the nail?
Or actually only the nail.
Only
But
the nail.
in some cases, I think that if the fracture is located distally to the isthmus,
Can we have the first slide, that we had a fracture? So, from my viewpoint, it's different to the subtrochanteric or diaphyseal fracture because the location is very distal. We know that even the normal people, if you have infraischemic fracture, there is a chance of lower stability by only the nail. And this AFF has has a longer time to heal. Then we need another stability. From my viewpoint, I will do that the augmentation plate at the time when we fix the nail at the first moment. And can I see that the first failure after your revision first revision surgery? Yes. Yeah. You did a nice job of augmentation plate. But I don't think we really need the bone graft because you did the close nailing. But the plate is quite long, but your screw is far too far. It's very flexible. So if I did, I will fix the screws near to the fracture site. That can be the better stability. So it's my the opinion. If I can change our practice, we should change stability better than this one.
Yes, Professor. Yeah.
I want to follow the.
You need to ask the panelists.
So for the revision surgery, do you have any suggestion for the number of the screw for the revision surgery? But because this time, Professor always mentioned about the far screw. But if we can put the closer, is there any definite suggestion for the screw number or cortex number?
Revision surgery, the basic principle, each fragment should be fixed with at least 6 cortex. Yeah, at least. Not 3 screws, it's 6 cortex.
Please, Professor Suthorn.
Yeah. What is the reason that you want to put this plate in? Right? You want to add more stability. But on the other hand, you just put few screw on the top and some screw below. Right? So that is not serve the purpose that you want to do. Okay. Anyway, why the screw is break? Because it's too much stability, it's flexible, screw is break. So the next point, you still see that there are a lot of empty hole. Even you don't remove the broken screw, you still have 3 or 4 screw on the top, 3 or 4 screw below. All right? I don't argue that what you have changed something and it healed. My question is, does it necessary to do like that? Instead of putting more screw in this construct, I'm sure you will get the same result. This is my opinion.
Thank you very much for the presenter.